Good afternoon. So hope you are all enjoying this workshop. At the outset, I would like to thank Mr. Chakrabani for offering us this opportunity to host this workshop here. I think we feel it's a very prestigious event in the annals of Aravind Eyecare system. And we'll talk about this aspect of quality. I mean, a lot of that maybe you may feel that little repetition, but I feel it may be really good. So as we go into that, the quality, all of you are very sure that all of you are handling a large volume of patients, each one of you. In that setup, we have to ensure good quality in the clinical outcomes, and also we have to ensure patient satisfaction, and also ensure equity in care. And I just would like to have your input what the quality means. When we say quality, is there somebody would like to say what it means? When you want to think about quality, 1 or 2 points.
Meeting the patient's desired expectations is one.
Yeah.
And 2 would be that as per standardized procedures, the outcome is the same as per standardization.
So we look at the patient's expectation, we look at the outcomes. It could be clinical outcomes, the complications. So there is the broad framework I would like you to understand when we talk about quality. The first and foremost thing is we hear about do not do any harm to the patient. That forms a base of the whole quality perspective, which is patient safety. So there are so many ways the patient's safety can be compromised. So recently there was a report from the UK National Health System where they've reported out of about 2 million procedures, they've reported a huge number of safety issues, wherein the safety has related in death for about close to 300 patients. About in 2,000 patients, there was a very severe harm, but some harm has been done to the patient. The safety aspect is quite important, the first thing. The second is, and in ophthalmology it's even more important. Why? Yeah, for one thing, correct. Second, most important thing, so we have to deal with 2 organs. There is, okay? So there is the right eye, left eye, there is always a chance that we may operate on the wrong eye also. So in that way, the safety part is very important. On that, then you have to look at the patient-centeredness. About that, we'll talk about that. How do we create a system which is geared to the patient, not towards the provider, not towards the doctor? Then this is about the efficiency. How do we maximize the output with the resources we have? The effectiveness means the outcome and the complications. And the timeliness is how do we deliver the care in the expected period of time. And the last is about equity at the peak. If you are able to do all these things, we should probably think about equity, which is doing the treatment in the same way to everybody. When we say safety, it always sounds very strange. We really do not know what we mean by that statement. It is to prevent or reduce the risk of harm or injury to the patient. And there are different goals. Broadly, you can put them into about 10 different goals. One is about identifying the correct patient, which means also identifying the correct site, correct procedure. Then how do we improve the communication between the caregivers, between the doctors and nurses, doctors to doctor, nurses to nurses, which may, if it is not good, probably also can compromise the patient safety. And also using medication. Okay, so if you do not know how much to give, what is the dose we have to give, it may be insulin or it may be an intravitreal antibiotic. And the infections, it could be a cluster infection or a sporadic infection. And also continuing the drugs. Sometimes very often after a very successful cataract surgery, the next day patient may develop a hemiplegia or some problem or a coronary event or a cerebrovascular event because the patient might have discontinued all the hypertensive medications because the doctor have not told them to continue that. So we come across several of them, and also fall from maybe the operating table or from the indirect ophthalmoscopy table or where the patient sit for slit lamp examination, all that can happen. And also one of the goal also to how do we involve the patient in their own care, in their own safety, and how do we improve the communication with the patient. So these are a lot of things. I am not going into the things. The broad goals are these ones. But the most important one is how do we avoid some of the major problems, like operating on a wrong person, doing a wrong procedure, wrong side, instead of right eye, left eye, that issue. It is not about surgery, it may be even any procedures, even a laser procedure. It may not be harmful to the patient. You may do a PRP in the wrong eye. It may not harm the patient. They may not lose the vision, but that's an error. Even giving a wrong, sometimes when we give the discharge summary, instead of putting the right eye, you put the left eye, that also probably will upset the patient. There are so many things. Every point we need to be careful. Till the point comes in and they go out, we have to be very careful about this particular point. So what we have done here for identifying the patient, we have tried many things. What we do today is, when a patient comes, the doctor asks the patient's name, look at the case sheet, and also get the ID card from the patient and sees whether all that 3 matches. So he also sees whether, very often we get the same patients with the same name. So we see whether the number in the case sheet and the number in the ID card are the same. So that is the one foolproof way. That is what the NABH also now recommends. Earlier they were not very clear about what we need to do, but now they are very clearly says. So when you have the case sheet, you also look at their ID card and see whether both are same, whether it matches. And sometimes we may not have that opportunity to do that in the operating room. Okay, so what we have done is we put a wristband for these patients with the patient's name, their MR number, and the eye to be operated. So if the patient's left eye to be operated, we put it on the left hand, right means on the right side. So here, after putting that, even one more person will check it in the medical record department itself, whether what is given in the case sheet, what is been printed on that wristband are all correct. The same thing is done when the patient goes to the ward, whether the daycare ward or the regular ward. There also it has been checked, all that. And then before giving the block by the sister, and before surgery by the team which operates. So at 4 different points we check all these things before we undertake the surgery. These are all some recent developments we have undertaken. Just it takes a little bit time, but it is really worth that time we spend on that. When we talk about patient-centered care, we have talked about this transparency, especially about the procedure, the package charges and all that. Sometimes if there is a complication, we have to manage, maybe a nucleus drop is there, we have to manage, we don't charge the patient that additional amount. Unless we have told the patient earlier that you've got this type of a cataract, where the chances for a complication is more and we may have to do that, then we charge the patient, otherwise we don't charge them. And we also, as you must have seen, every patient is accompanied from one point to the other point, either from medical record department to the unit or from the unit to the specialty clinic. We always take care of the patients so that they don't have to look around, find it for themselves. We also pay a lot of attention to counseling, whether it's a paying patient or a free patient, because we feel that unless the patient is involved in the care, we may not be able to achieve the desired results, especially if you are going to give the post-operative medication. If the patients are not going to apply the medication, if the patients are not going to recognize the complication they have, the redness or the pain, when they have to seek the care, where they have to come, all that is very, very important. So we have a way of doing it for the paying patients and for the free patients, so that in the way they are all used or accustomed to listen. And then these are 2 basic things. I'm just giving you some examples of what can be done towards the base of the pyramid. And then the other thing is, how do we improve the efficiency and also effectiveness of the whole system. So these are some of the principles, some of the things we need to do if we have to bring in efficiency, effectiveness. One is proper documentation systems, clinical protocols, standardization of procedures. About Dr. Aravind also spoke about that. How do we use the resources meaningfully? How do we have good quality and reliable resources? And about staff training and discipline. These are all some of the important things that will contribute to efficiency and also the good outcomes. So regarding the medical records is we feel is very important, and that is why if you have seen the way we have set it up, if a patient walks in, we have about 10 lakh records. If the patient had the last 2 year records are there in the ground floor. So they'll be able to pick up the record within 2 minutes, less than 2 minutes. We also document if they are not able to pick up a record at the first attempt, where it should be, that is documented. And we also know who had filed that case sheet wrongly last time. Okay, so we'll be able to see who had filed it, and probably we'll ask that person for the explanation. So we'll be able to get all the records very easily. The reason why we should have a medical record is very important. For example, I'll just show you this Word document. Are you able to see that from there? Okay. So for example, let's say you've got seeing every day about 120 patients. Of that, about 50% is your follow-up patients, which means like 60 patients are follow-up patients, 60 are new patients. We all know that it takes time to work up a new patient. When a patient comes, you have to do the vision, then we have to do the refraction, we have to dilate the patient, see the fundus, intraocular pressure, blood pressure, all that, it takes time to do that. You have put a time of 60 minutes. But the same thing when a patient comes back for a follow-up, we know that whether if you have a record, you know this patient doesn't have glaucoma. We know that what is this? Refractive error. So all that makes the workup much, much easier. Our nurses the optometrist can see the patient. If the patient says that they have come for a regular follow-up, they'll do the vision, refraction, check the intraocular pressure, and then dilate for the doctor's examination. If it is not that, a doctor has to see, write down all the preliminary findings, do everything, then decide about dilatation and all that. So that way we are able to save at least 40 minutes. But for handling this 120 medical records on a day, you need only 2 staff. So, but what you gain is about 40 man-hours. You are saving about 40 minutes per old patient, which means it calculates to about 40 man-hours, or roughly it is about 4 or 5 doctors' time. Okay. So that way, having a good medical record department, keeping all the records in the department itself, will be able to save a lot of time. And again, if you have the medical record, that forms the linking process. All of you are multi-doctor setup. You've got several doctors, several departments. So the patient has to move from one department to another department. And many of these diseases, patients who come to this RIO or the medical colleges, or patients who have glaucoma or diabetic retinopathy or hypertension or systemic problems. So if you have that thing, it will also serve as a good linking process. And again, we also stress upon the protocols. If you hear about Dr. Junaid was giving the talk today morning, and he mentioned about SOP, that is standard operating procedures. This is nothing but for a clinical department, they means the clinical protocol. So when any disease, for cataract means how you are going to manage, what are all the pre-operative investigations you will do, what are the surgery means, what is the technique that will be followed, what are all the techniques that will be followed, and post-operatively when will you see the patient, what are the medications that will be given, when will you give the glasses. So that is kind of the protocol. For example, if you for example, about advising surgery for the cataract patients. Here, broadly, the patients are divided into 2 categories based on the vision. So patients who have got a vision of less than 618, that is 624, 636, 668, there what is the timing of surgery? If a patient has got a vision of like 612 or more, what is the category? How do you? There it says, if a patient has got a vision less than 6/18, if they got enough cataract, then you, based on the amount of cataract, we are given a timing. You advise the patient within a month, ask them to get operated within a week, or you admit the patient immediately, telling them somebody has got a mature cataract. We really convince the patient to get admitted immediately. But somebody has got a good vision, 612, why should we operate? So then you need a criteria, like subjective criteria. Patient says they have got a glare, disability, they are not able to do their work properly. And objectively, you see there is a central PSCC. Or patient has got only nuclear sclerosis, but they need a laser, or they need a fluorescent angiogram. So if you have some clarity, then it also becomes easier to teach the residents, anybody who joins your department, may be able to orient them, what is the protocol that needs to be followed here for advising somebody for surgery. Similarly, there are also guidelines available for glaucoma. When you see a patient, this is the intraocular pressure level, this is the medication we will start. This is the pressure level, we will advise surgery. Okay, when a patient, when they'll come back for follow-up, what will we see? If the pressure is normal, what will we do? If the pressure is not normal, what we will do? So if you have a protocol to follow, then it also becomes easy. So many of this is available from some of the, like an American Academy of Ophthalmology has got a protocol for most of the diseases. Canadian Ophthalmic Society has got. Recently, Delhi Ophthalmic Society brought a protocol for the cataract surgery. Like All India Ophthalmic Society has brought a protocol what we need to do for prevention of surgery infection, even though it is debatable. So we have protocols. If you have a protocol in a multi-provider setup, it will bring in uniformity within the group. And you can, all this decision making, what type of surgery to be done, and we also have, depending upon, we have a protocol to classify the patients category A, B, C. So category A means who can operate, B who can operate, all that we have internally. So that when we have 200 patients, there is no difficulty in the decision making for the staff who are there in the block room or the preparation room. So this is mainly to eliminate the variations at various stages. And again, the standardization of the procedure. So the standardization means it's streamlining the workflow. Whereas the earlier one we talked about clinical protocol, it's about clinical decision making. The standardization is for the processes and the procedures. It may be a cataract surgery, it may be a refraction. Here, because the multiple people are involved, when you do cataract surgery, you are not the only person. Somebody has to prepare the patient, somebody has to clean it, somebody has to administer the block, somebody has to bring them, somebody has to drape, somebody has to take care of the sterilization. So we would like each person to understand their responsibility and the process they are involved. What is the outcome? And if there is a variation, we can always find why that happened, what that particular person has to approach it or do it differently. So this is just a flow chart for the outpatient department. This is what we follow, like initially reception, the registration, we do the vision, or if there is less patient, we do the refraction, then they see the doctor, then the dilatation, then the doctor sees. So before that, before they come to the dilatation, they also check the intraocular pressure. So this is a way we have laid out our work. For example, Mr. Tulasi showed the way we conduct the eye camp. Kim also showed. This is something we have doing about 1,500 eye camps. The same system is followed for every camp, right from registration to the counseling and the transportation of the patients and back. So for example, I didn't bring the refraction card. So we asked our staff to do all these things. Now they have to register the patient complaint, they have to do a torchlight examination to what the patient's condition is, check the vision, find out the glass power. You must have seen I think all of you have got the folder, the refraction card you must have seen. You have it? Yeah, yesterday I must have given. The refraction card completely reflects this work process. So when you tell somebody you have to do all these things, they may not do it. They may not be able to do it. But if you translate it into a case sheet where all these things have to be captured, then this will happen. So where what we tell them as a best practice, if we have to convert it as a system, that refraction card is one example. The other important concept we want to have a good efficiency and a good outcome is delegation of work and balancing of resources. So we talked about that a little bit today morning in the HR session. The basic principle is all the routine skill-based work is given to the paramedical staff. They must have told you. So the physicians may not enjoy doing this kind of a repetitive work. They need much more challenging work like surgery or decision making in a complicated outpatient case. They may not be very interested to take the blood pressure for 30 or 40 patients or do a scan for 40, 50 patients. But they may be interested in interacting with the patient, finding out what their problem is, making an appropriate diagnosis and treatment for that. So similarly, the way we try to eliminate some of the unproductive work to be done by the doctors, we also would like to eliminate some of the clerical work done by the paramedical staff through computerization of the records or delegation to the ward secretaries. And they are also not in many hospitals. The nurses are also responsible for the housekeeping. Here we got a separate team who will take care of all that. So by that way, the patient, the nurses can put all their effort in taking care of the patient and giving the best of their nursing care. So if you have this kind of a system where you have a doctor who is supported by paramedical, who in turn are supported by some of the support staff, we will be able to get not only efficiency but also better outcome. Because when you do certain things repetitively, okay, so when you create an opportunity for them to do more volume, the skill level also goes up quite a bit. And this is an example how you allocate the resources, not only the manpower but also the equipments, instruments, the material resources. The material resources are allocated and also the manpower is allocated. We may be able to use the doctor's time much more efficiently, because now in any setup, Dr. Aravind was saying today morning, ophthalmology is a very complex thing because of the technology. So today the ophthalmologists are a very important resource, and also the equipments are very, very important resource. So we need to find a way how do we maximize the productivity of these two elements. So only if you are able to do that, we may be able to achieve the goal. The goal in the sense, in spite of volume, you can give a good quality outcome. Okay. And just about the surgical technique and technology or buying equipment, we always see whether buying this particular phaco machine, will it minimize the complication? Will it improve the visual outcome? Will there be less corneal edema? Will I see better cornea the next day? Will it enhance the productivity? Will I be able to do it 1 minute or 2 minutes of my time can be taken away by buying this new equipment? Will it improve the satisfaction for the patient, or will it reduce the follow-up? All that will decide whether we buy a new equipment or not, or we adopt a new technology or not. Today, any procedure, earlier used to have only one technology to do it. Today there are more than one technology to do that. The other important thing is the reliability of the resources. Okay. For example, regarding the equipment instruments, our bottom line is how do we minimize the equipment downtime. Okay, it's not about buying the least expensive or the least cost equipment. So we buy good quality reliable equipment even if it is expensive. The main thing is we don't want that equipment to break down. The other thing is we also have an in-house biomedical team who will be able to maintain all these instruments, equipments, calibrate the especially the tonometers and all that. They'll be able to do it. So if you look at all our hospitals, we have close to about 45 technicians who are in the biomedical team. And wherever it is not possible for the in-house team to maintain it, we have a service contract, and we see to it that they come and do the service or the maintenance at the appropriate time. And yesterday, some of you must have seen a black and white chamber in the operating room. So where now very often we know some of the dirt particles, maybe fungal or something within this glass bottle can be the cause for a cluster infection. So we have a chamber where it's got a black and a white dark background. So where now this bottle can be checked on the black background for any white particle, across the white background for any colored particles. So now we will be able to see that thereby, if there is anything wrong, any impurity is seen, we kind of reject those bottles. So we do it for every that bottle that before it goes for autoclaving. And we also check the pH of all these solution, and also we check the culture and sensitivity for every batch. At least 2 bottles, 2 samples will go for that. And we try to use the same resource. We never try to change the company people because they give a better price, a lower price. We try to stick with the same company, and we try to build a good relationship with these vendors also. So we also take them as part of our team. We give them our input. What is it we want? Is there anything we want differently? Because we are involved in designing the drape for the patients. All that we have done according to our need and specifications.
It's meant for the trainees to get familiar with the foot pedal.
So this is just to show you about our surgical training. Our logic or the philosophy which we follow in our hospital is, whenever we get a new postgraduate, new fellow, we try to see whether they can be made productive at the earliest possible time. We don't wait for them to take 3 years to become a good surgeon. We try to do that within the first 12 months. Like within the first 6 months, they go through a wet lab training so that they are very familiar with the surgery when they are going to operate on the human eye. Then we take them through a step surgery, wherein the first day they do one step, maybe like cutting the conjunctiva or applying the cautery. The second day they probably make a small incision. The third day they do a capsulotomy. Like within 10 days they can do about one, they'll be able to operate independently. When they do on the first days, probably they'll do it on 2 or 3 patients, but as they make progress, they do one surgery. So after that, we make sure that they do one surgery every day under the care supervision of a doctor. So that, the idea being, if you are able to give them that volume the beginning, we'll be able to train them or mold them much better. If you are able to spend that time, quality time with the trainee at that point of time, we don't have to sit with them for the rest of their training period. And also, once they are put into a regular surgery, they'll be able to handle large volume. At least by 18 months, or most of the fellows, by 18 months, they'll be able to do large volume, like 20, 25 surgeries on a day. Postgraduates, by the time they come to their final year, they'll be able to do 30, 35 surgeries. So that is our idea, is least supervision. They'll be able to do good quality surgery. They'll also be able to contribute to the volume. So that is how we have structured all our training. Similarly, even the outpatient department, we try to discuss with them so that they'll be able to independently manage the patients by about 18 months of their surgical training period. So we have a system to train this for either it is for nurses or for paramedical workers or for even a storekeeper or housekeeping. On all areas, we have systematic procedures for training, and we also encourage the mid-level staff to get involved in the training. So as they get involved in the training, their level, their competence also goes up. They can perform much better. And the work also, whatever work they do, we have always seen when a doctor is given responsibility for training the juniors, the very next month, their quality also improves quite a bit. And again, the overall work culture, discipline is very important. The commitment of the leadership, whoever is involved in the training or the overall healthcare facility, the attitude for perfection, and also the passion to do the best for the patients. All that probably will go together to improve to provide the care for the patients.